everybody. We're going to talk about getting musculoskeletal. And I thought I'd get your attention to kind of throw out something there that's a little different. Bones. We are going to be dealing with bones in these lectures, not bones that's on TV. And I'm sorry to say it probably won't be quite as interesting if you're into those kind of TV shows. I know people at our house are. I have daughters who binge on it. Okay, so what are you going to know? Well, one thing, be familiar with how the joints work. Understand the terms. You know, what is extension, flexion, hyperextension, those kind of things. Internal rotation, abduction, adduction. You want to know all about that, okay? Because you want to be able to explain that to your patients. And the same way when you demonstrate it, you want to make sure that you're demonstrating the right term with the right action. Okay, so one of the things we're first going to talk about is when we have an injury to an extremity, what do we usually do with it? Well, one of the things we might do is put a splint on initially. Here's a picture of a air cast or air splint. Pretty common when someone goes to the emergency room and has a sprain. So they're going to splint it, support the extremity, and then most likely they've already had x-rays, and then they're going to go to the orthopedic doctor for follow-up. Another common thing is we put a cast on a patient, right? So that's another thing you need to become familiar with is cast care and how to take care of the patient with casts. It's important to note with that, you know, we're always, whenever someone comes in with any type of fracture or potential fracture, we immobilize it at first, and most likely immobilization is going to be via the splint. And then once the x-rays are done and the fracture is set, then the cast is placed to make sure that the fracture stays aligned. Casts can come in many shapes. You can have a cast, you know, long arm, short arm, leg cast, full leg, half a leg. I mean, it all depends on where the injury is. There's even things like body cast. Casts can be made of plaster of Paris or fiberglass, which is lighter. It is water resistant and dries rather quickly, whereas the plaster of Paris plaster cast can take up to 72 hours to dry. So when we have a patient with that, especially when it's a plaster cast, we want to, until the cast is dry, we want to handle it with the palms of our hands so we're not making any indentations into the cast, and therefore maybe messing with the alignment of the limb. No matter what type of material the cast is, we're always checking for neurovascular status. At least every hour for the first 24, and we're also assessing for pain. Remember, neurovascular, that's circulation, sensation, and movement. So for this guy with this nice cool cast that he's got on, we're going to ask him to wiggle his fingers. I'm going to touch the tips of all his fingers. I'm going to compare the temperature of those fingers compared to his right hand. I'm also going to check cap refill, and we're going to assess his pain level. We will keep the cast elevated above the level of the heart for the first 24 to 48 hours to prevent edema of this extremity. We always want to assess to make sure the cast is not too tight. You should have at least room to stick one finger in there. We do not want to stick things down the cast though, but it's okay to do that. We're going to teach the patient if there's any issues with any foul odor coming from the cast, anything like that. We want to make sure they call us right away about that. Any swelling, pain, those kind of things, and we'll talk about that when we talk with complications and compartment syndrome. They should report if it becomes soiled, especially, it happens, with feces or emesis, something that needs to be taken care of right away. You want to teach them how to cover the cast for showers as well. And then always, always encourage them to report any changes. So now, say I'm assessing it, they can wiggle their fingers. And then tomorrow when they wake up, they can't wiggle their fingers. They need to call their provider. Also, I'm going to teach them about, signs and symptoms of complications, as well as also, if it's a lower extremity cast, is it weight bearing, non-weight bearing? We'll probably have to teach them how to use crutches if it's non-weight bearing, those kind of things. So definitely want to get into that with them. All right, another way we can deal with a fracture is especially, and I'm going to show this to you guys so you can see what a closed reduction procedure looks like. They're going to medicate this gentleman, and you'll notice, when I'm going to fast forward here, you'll notice that, try to get to the point where I want. So the person on the right and left of the, person on the right and left side of the gurney are going to apply pressure. So see that sheet that they have there, they're going to push down on that to keep the patient, prevent the patient from lifting up. And you'll see why in a minute. They're administering the sedative now so that he will be, hopefully won't feel any of this when they do this. This gentleman was in a trauma earlier in the day. I believe it was a motor vehicle accident. Still trying to medicate the guy. Okay. So a couple things I want you to look at here. You can see that they're providing counter traction. Okay. And then you'll see the orthopedic attending. What he's going to do is, notice what he's doing. He's assessing the extremities, comparing the right to the left. Okay? He's comparing, you'll see how the affected extremity is shorter than the right. So see how he gets up there? Now he's providing the traction and the other guys are providing the counter traction, and they're getting the limb, and then they're calling for an x-ray at this point. Okay? So then what they're going to do is get an x-ray to determine if it's in the right proximity and that everything is taken care of. So that's an example of a closed reduction procedure. Commonly used for, that was a hip dislocation. You hear people dislocate their shoulder. It's probably pretty common, or hopefully not too common for people, but can be common, right? All right, so moving forward, we're going to talk about another way to deal with a fracture is external fixation, okay? These are, you can see that it involves immobilizing the fracture using pins and wires. They're used to, sometimes if there's a non-union fracture, they may use this as well. Advantages, there's definitely stabilization of the fracture immediately. There's also minimal blood loss. And it maintains the alignment. We also have to provide pin care to those pins to prevent infection. That's critical for these patients because they do have an increased chance of developing infection, osteomyelitis. Again, you're going to elevate the extremity, always monitoring neurovascular status and skin integrity. Pin care should be performed about every 8 to 12 hours. And we're monitoring the site for any drainage, odor, color of that drainage, and redness. We're always looking for symptoms of pulmonary embolism or DVTs. And then we're taking precautions to prevent that from occurring, so they may be on compression stockings or sequential compression devices. Patients most likely are going to home with this device, so they're going to need to be taught pin care. And then we're going to have to probably make some adjustments on their clothing depending on where it is. Activity will be restricted most likely, so that you want to definitely make sure that the patient can verbalize how and what they can and cannot do. Another example that we deal with fracture is open reduction internal fixation. This is where they go to the OR. And so there's an incision, and then internal fixation is where they put the plates and the screws, the rods or prosthetics in to support that fractured area. Nursing actions will involve monitoring skin integrity. We want to make sure that we're also doing neurovascular assessments on these patients. We're going to observe dressings or whatever, if they're casted afterwards, whatever wraps on them, we're going to make sure we're evaluating and checking for edema. Always watching for these patients for fat and pulmonary embolisms. Taking measures to prevent DVTs. Because they went to the OR, they're most likely going to be in the need of pain medication, so we're going to be watching and assessing for that. Watching for signs and symptoms of infection, so we're going to be checking vital signs, monitoring labs, looking at those white blood cell counts and ESR rates. And if we're doing wound care, we're definitely doing that as ordered, and depending on how it's ordered, definitely either would be a sterile procedure or a septic procedure. We're going to increase physical mobility as appropriate. We're going to consult physical therapy for these patients and occupational therapy. Remember with these patients, especially if they've been in bed for a couple days when they first get up, we want to watch them for orthostatic blood pressure changes. So we're going to get them up slowly. Remember, while they're in bed, we want to turn and reposition them every 2 hours and monitor that skin integrity. Very important. Nutrition, they're going to need to increase their caloric intake. They probably will need calcium supplements, and they may benefit from small, frequent meals. And we're also trying to prevent constipation. Another thing that we might do for these patients is put a electro bone growth stimulator. This will help facilitate healing, increase calcium uptake, and activate intracellular calcium stores. It does definitely increase the bone growth factor production. This procedure can be non-invasive, semi-invasive, or invasive, depending on what type of mechanisms they've decided to do. It can be used up to 10 to 12 hours a day, depending on the type that they're using. And what it does is, lots of times they'll use this for the patient that has had some delayed healing or maybe risk factors for developing delayed healing. So that could be a potential. Other things we would see our orthopedic patient need when they've been injured is medications. They lots of times will need peripheral or central muscle relaxants like a stoma, Flexeril, Robaxin, because they not only have pain, but they also may have some spasms. If they've broken their skin, we need to assess to see if they need a tetanus shot. And then most likely, if they've broken their skin or they're going to the OR, we are going to give them some IV antibiotics prophylactically. They have to be bone-penetrating IV antibiotics. Something like a cephalosporin would be most commonly used. Other things we want to do for these patients is nutritionally, we want to increase protein in their diet. We would love them to take vitamins B, C, and D, calcium, phosphorus, and magnesium, because this will all ensure optimal soft tissue and bone healing. Increase fiber and increase fluids to prevent constipation. Most patients, if they're up and about in rehab, can tolerate 3 well-balanced meals a day. But if we have a patient that has like a spica cast or is not up and about as much, they may need 3 smaller meals a day. Also, we could increase fiber to prevent constipation as well. Potential nursing diagnosis for this population, and believe me, this is not the only ones. These are just kind of the most common. We can have risk for peripheral neurovascular dysfunction related to vascular insufficiency and nerve compression secondary to edema and or mechanical compression by traction splints or cast. We'll have pain, so acute pain. Impaired physical mobility is another one. So what do we want for the patients? What would be goals? Well, we'd want them to have satisfactory pain relief, achieve maximum rehab potential, and heal without any complications. One thing we can work with them in teaching them for prevention of injury is teaching them safety precautions, especially to prevent injuries while at home, or driving, or when participating in sports. Nurses can become an advocate for personal actions known to reduce injuries. That could be like use of seatbelts, driving within posted speed limits, warming up before exercise, stretching, use of protective athletic equipment, no drinking and driving, no use of illicit drugs. We want to definitely encourage individuals to participate in moderate exercise to aid them and maintain their muscle strength and balance, because that will help prevent falls later in life. You want to reduce falls, especially in the elderly, so we're going to assess their living environments, and you guys remember this from foundations. No scattered rugs, clear pathway to the bathroom at night, a good lighting, maybe night lights so they can see where they're going at night. And definitely for the women, we definitely want to stress the importance of adequate calcium and vitamin D in their diet, or supplements most likely, especially if they're postmenopausal. Most of these patients are going to have to go to the OR, not all, but a good majority of them will. So preoperatively, we want to do a lot of teaching and just general pre-op teaching. You guys went over this in foundations, I know. But we're going to talk about the effects of immunization, what's the normal course of treatment post-operatively. Are they going to need any assisted devices? Who's going to help them at home? Is anybody going to be able to help them at home? Are they going to need rehab when they first go home? Make sure they understand the use of pain medications and about the pain scale and what would be a reasonable pain level for them. They will not be pain-free post-operatively. But we need to discuss with them what is a adequate pain level for them. And then you're just going to get general good history on the patient. Post-operatively, we're going to do frequent vitals, just general principles of nursing care. We're going to make sure that you're doing frequent neurovascular checks at least every hour, as well as assessing pain every hour. Going to monitor for bleeding and drainage. And then if we're doing any wound care, we're checking that, draining any of the drains are drained. We're using aseptic technique when we're draining any drains. And then in some cases, if they've lost a lot of blood during surgery, they may do reinfusion system where we reinfuse their blood that they lost during surgery. That's a potential. Now, it doesn't happen with everybody. But definitely overall checking them out, and just post-op general. I mean, airway's a big thing in the PACU, for sure. Goes along with it, but because they've had orthopedic surgery, I gotta stress those neurovascular assessments are critical. Complications. Remember, there's complications of not moving around too much, immobility. So constipation, we talked about that, increasing fluids, fiber in the diet, trying to get them moving as fast. Renal calculi, they are definitely at risk for that as well. And we want to make sure that we increase fluids to kind of flush out those kidneys as well. We can also see rapid decongestioning of the cardiopulmonary system, and the main risk for this is risk for falls because they have orthostatic hypotension. So we want to make sure that we, when we're first initially getting up the patient, sitting them on the side of the bed, dangling, letting them get reacclimated, and so assessing them continually through the process. Are they dizzy? Those kind of things. And lastly, but certainly not important, is DVT. Obviously, the best way for thrombus to prevent is ambulation. Most likely, these patients are going to be on Lovenox, some type of anticoagulant as well. They may be on compression stockings or some type of SCDs, sequential stockings. So those are all possibilities for these patients, and we need to be aware of what our nursing responsibilities are for that. Okay, so that's part of musculoskeletal. There'll be a few more for you guys to view. Trying to chop it up a little bit so you're not stuck listening to like one really long lecture. Okay, all right, I'll talk to you guys later. Bye.